Thank you very much, everybody, for coming along. I know some of you, I don't know others, but we welcome everybody along. So I want to say to you all, thank you very much for coming along today, and for those listening to this at a later date. Tara Renton, who should be joining us today, the Professor of Oral Surgery at King's in London, asked me to do this talk about Ehlers-Danlos after I messaged her to say I was so pleased to see that she had mentioned Ehlers-Danlos in a talk about TM joints and facial pain that she was doing. Ehlers-Danlos is a very much misunderstood and underdiagnosed connective tissue disorder, and I want to show you how it is so relevant to all of us on a daily basis. So let's tell you who our audience is. We have invited people along from the International Classification of Orofacial Pain, British and Irish Society of Oral Medicine, British Association of Oral Surgeons, Frederick and his team from the Face Your Pain website, the Get It Right First Time TM Joint, Royal College of Surgeons guideline as well. People are here from all over the world. So I feel there's maybe no point in us doing this live unless you want to keep throwing in your questions. Let us know what you think, and we'll try and answer your questions as we go along there, okay? So let's move on there. What is the problem? No other condition in the history of modern medicine has been neglected in such a way as Ehlers-Danlos syndrome. And this was said by Professor Graham, who is a rheumatologist. So what we want today is to open your eyes, okay? This is just the start of us telling you about Ehlers-Danlos, and we're happy to organise any other sessions that you would like. Expected learning outcomes, we need to run through those. We need to know what the signs and symptoms of Ehlers-Danlos are, show greater understanding, know how to modify the treatment, and know when and where to send our patients to get help. We've now got 29 joined us, and that's absolutely brilliant. So let me tell you who we all are here today. My name's Audrey Kershaw. Some of you may know me, but I saw a lot of names on the list that I didn't know, but lovely to meet you all. I'm a specialist in oral surgery. I work peripatetically throughout Scotland, and I am an EDS allied clinician. Pleased to introduce our co-presenters. We were going to be very pleased to have Alan Hakim along with us today, but I think you've all seen the email that Alan sent to you. We sent that out yesterday saying he was very sorry he couldn't join us, and he hopes to work with us in the future. Alan is a consultant in rheumatology. He's the Chief Medical Officer of the EDS Society, and he leads the EDS ECHO courses, trying to teach clinicians, healthcare workers about Ehlers-Danlos. Delighted to have yourself, Linda, join us. Okay, Linda Bluestein. Some of you will know Linda from her Bendy Body podcast. So Linda, would you like to tell us a little bit about yourself? That would be great.
Sure. I'm thrilled to be here because I feel like this is just such an incredibly important topic. And you never know where these patients are going to show up first. And the first person who's going to recognize, hey, this is something unusual. And the thing that probably drives me the most crazy is hearing there's nothing you can do. And there's so much that can be done for people with EDS and HSD. So I'm so happy to be involved in this. And I fell into it kind of by accident, like probably most people. And I host this podcast. I also have a clinical practice called Hypermobility MD, where I do see patients. So
yeah, that's great. Thank you, Linda, and we'll hear much more from you as we're going along. A very important colleague to ourselves is Janet Gravener. Janet is travelling, so she's on listen-only mode. Janet has got an amazing clinic in the seaside town of Cellardyke, and the waves come crashing up against the garden walls when you're sitting in her clinic. Enough of that, though. She is importantly an EDS Society allied osteopath. She looks after over 1,000 EDS cases. She's got a further qualification in headache management from Edinburgh University. I got an email out of the blue from Janet a couple of years ago, and I thought, who is this? And is this real? It was completely and utterly real. We have joined forces, and I don't know how I would manage without Janet. Since I have met her, I have swamped her clinic with all the Ehlers-Danlos, the possible Ehlers-Danlos cases I find in my oral surgery practice. I've learned a lot with her and I work very closely. We seriously need many, many more Janets. We need to clone her because the pathways for care do not exist. Anne Sutherland, would you like to tell us a little bit about yourself? Anne is a very dear colleague to me, and if you'd like to tell us something, Anne.
Thank you, Audrey. Hi, guys. So as you can see, I am a volunteer with EDS Support UK. That picture of me is actually taken in the Scottish Parliament this year, where we held an exhibition. We've also had roundtable debates, and we had an event last year. So primarily my role in EDS UK in Scotland is basically working with politicians, trying to develop and provide care pathways. We're working with NSD, we work with the University of Edinburgh to help with research, and I also work with clinicians, the likes of Professor Stuart Ralston from the Western General in Edinburgh, who is head of rheumatology and is extremely keen to help us sort of move things forward. So there are lots going on. We're also now getting some traction in the Welsh Government, the Northern Irish Government, as well as the UK Westminster Government. So
well, thank you. Thank you very much, Anne, and we'll be hearing from you as the talk goes on as well. We have got 3 very special guests here today as well. We don't have photos because they've still to send me their photos. All of these, I don't know if they found me on Clinic or I found them. The 3 of these guys very openly shared their stories, and we've got to be so, so grateful and humbled to them for doing this. So we've got Emma, we've got Byrdie and Jacqueline, and we'll be hearing from them as we go on. And it's very kind of you to share your stories. Emma has worked with me on many of these talks. Byrdie and Jacqueline, this is the first ones that you're appearing on with me, but we welcome you, and this is great. So these are my 2 poodles. Before I got poodles, I never noticed poodles anywhere. But once we are aware of something, we can't help but see them. Now I see so many poodles. I don't make up that there's poodles wandering down streets or running through parks. They are there. And they were always there, but I didn't see them. And this has been my experience of Ehlers-Danlos syndrome. So what am I talking about today? We all use different terms, and Linda, please join in and help me here. This was supposed to be a slide Alan was doing. There are all these different terms: hypermobility syndromes, hereditary connective tissue disorders, Ehlers-Danlos syndrome, hypermobility spectrum disorder. Do you want to just give us a 20-second chat on those, Linda? Would that be okay?
Sure. So I like to use the term symptomatic joint hypermobility to refer to anyone who has joint hypermobility or joints that have greater than expected range of motion. And underneath that umbrella falls, yes, all of these things that you've mentioned here, the Ehlers-Danlos syndromes and hereditary connective tissue disorders. Most of those have known genes, except for the hypermobile type of EDS. We don't know the gene or genes yet for that. And hypermobility spectrum disorder is the term we use for people who have symptomatic joint hypermobility, but don't have another diagnosis to explain their condition.
Yeah. So that's great. And we're going to go into so much detail as we go through this talk here. Yep. So what are these conditions? They're a collection of genetic collagen disorders. Collagen is a protein that makes up the main building blocks in your body. Every body system can be affected, and it tends to be an illness you cannot see in people. So looking at the likes of Byrdie and Emma and Jacqueline, they can look very, very well, and people don't necessarily believe that they are ill. Most of the conditions, as Linda said, there end up being hypermobile EDS or another rarer form of EDS. We have to be very open-minded when I find patients on Clinic as to what they are. We just give a broad term like hereditary connective tissue disorders. I'm not qualified to be diagnosing, and even those that can diagnose, unless we have a genetic test, it's very difficult to tell what they are. So don't get mixed up with all these terms we're using today. It's one and the same thing, just about. We also need to be open-minded, Linda, because the way I come at this is not from the joints necessarily. I come at it from an oral surgery point of view, which is what a lot of our colleagues here today come at it from. So I come at it from, we can't get them numbed up and other things within their medical history that I find. You touched on the hypermobility of the joints, Linda, and I think we can say here as well, you can have generalized hypermobility, localized peripheral, or historical. So it's all quite complicated. We don't need to get too bogged down in it, but just to give you a bit of a tester there, yeah? So Linda, we might, we'll maybe talk about this one together, or let me see how I get on. I'll maybe call on your help. So this is the 2017 International Classification of Ehlers-Danlos. And there are 13 types of Ehlers-Danlos on this. When this came out, very quickly, a 14th type was found a few months later. And now, Linda, I believe there's even more than 14 types. There's another 3 or 4 more types, Linda, being discovered?
I believe that the actual formal recognition is of the 13 types, or the 14 types, excuse me, the 13 types in 2017, and then yes, that 14th type, and now there's some suspicion of some other
ones.
Positive factors.
Yes.
Is it okay if I put in the chat a link to the red flags that make us suspicious of a rare type? Or you're going to get to that? You're going to get to that.
We're probably going to get, but please put it in the chat, because you shared that with me recently, and that's a great link. So I believe there's going to be a new classification out in 2026. So if we sort of, I've got my thing here. My IT guy, could you come and make this red for me, please? Thanks. So there's 13 different types. You can see some of them are autosomal dominant and others are recessive. Yep, thanks very much. Thanks very much. So you can see all of them here have a genetic basis and a protein disorder found, apart from the hypermobile types, and that's that type there. Yep. Hypermobile EDS is by far the most common, and there's no test at present for it, but we're going to talk about that in a little bit as well, Linda. I'm going to get you in for one of the slides I'm bringing up there. Since I started working with Janet, we have started discovering quite a few rarer types. We've found quite a few classical types, which is where you've got the stretchier skin. I've found a cardiovalvular type who'd already been diagnosed. There's the vascular type where, as an oral surgeon, I maybe have my suspicions raised because their skin is maybe see-through. We have, Janet and I, maybe picked up an arthrochalasia type. There's all these different types, and just because hypermobile type is the most common, we shouldn't just think it's hypermobile EDS. I also very excited a few months ago, I picked up my first, I think, periodontal EDS. He is away for genetic testing at the moment, but we're pretty sure he's a periodontal EDS. So we're just really saying Janet and I are open-minded when we find these, and Janet does an absolutely wonderful job of investigating them and taking them forward, which is probably what Linda does in her work as well. So let me tell you about my experience of Ehlers-Danlos syndromes. Yep. So up until 2018, I knew there was something going on with our oral surgery patients, and I did not understand. Some of them wouldn't go numb, some of them weren't anxious. I just knew something, and I didn't know that it might take me 30 years or so to figure out what this was. And one day I was talking to a friend about a patient, my friend Joy, and I suddenly found the answer. So fast forward to 6 years later, I now find around about 13% of my oral surgery cases are undiagnosed connective tissue disorders. So that makes it about 1 in 8 of my patients. Now, I know that sounds a lot, but I'm very, very cautious of what I do. And most of these, when we pass them to Janet and we follow them up, our suspicions have been right. So this year so far, again, I know this is a horrendous figure, but this year so far, I have noted 120 or so connective tissue disorder cases. And we have never been wrong, never proven wrong when we picked up a case. So let's turn it around here. Let's compare this to the known prevalence. So when I first discovered about Ehlers-Danlos in 2018, these were the current figures, 1 in 3,000 to 1 in 5,000. So I thought, that's okay. It's going to be another 7 years at the rate I work before I find another one. But 2019, a Welsh study then showed it to maybe 1 in 500. And then 2024, a northeast of England study showed 1 in 227. So Linda, let's have a bit of a chat about this, yeah? What do you reckon the true prevalence might be of this?
So I was really wanting to ask you, when you said 1 in 7.8 patients, that's a staggering figure. Are you saying that 1 in 7.8 of your patients test positive for a known genetically defined type of EDS? Because that would be really.
Yes. So what we've got to remember, what we have to remember here, Linda, is I don't see a representative sample of the population. I work as a specialist in oral surgery. I get the cases that won't numb up, that are anxious, and have other issues like this. Yep. I see patients very differently than yourself sees, because you see patients who are suspecting EDS and they come to you, so the way we see things. Speaking to Alan, I've spoken to Alan about this, and he says, go with it, Audrey. We are doing the right thing. Any case that I have sent to Janet, and as you're aware, Linda, it takes time for the patients to get to Janet. It takes time to get genetically tested. As I said, all of the patients we've followed up to the end of the journey, however long that is, 6 months, a year, we have never been proven wrong. So I'm very happy to chat to anybody about this. Yep. And I think we're seeing more and more, but I don't see a representative sample of the population. But I think most of us would agree it is probably more than 1 in 227. Yep.
I think when you consider all of the types of EDS, including hypermobile EDS, which of course does not have a genetic marker, so those patients would not show up with a genetic finding.
Yeah.
Consider that and HSD, so hypermobility spectrum disorders. I think it's probably like 1 in 100. That's more my opinion than something that I have data to back up. But it's much more common than we have.
It's much more common than we thought. Yeah. So now everywhere I go, I see poodles. This is not a mirror image. These are actually these are 2 other poodles we bumped into in Perthshire when we were out for a walk. And this is now the same as Ehlers-Danlos, okay? And it is unbelievable how you guys, Emma, Byrdie, Jacqueline, you gravitate to my clinics. So is this really relevant to us, to you guys in the audience? I just want to run through the reasons why, as oral surgeons, oral medicine guys, why you might come across them. So failure of LA, the mucosa tends to be fragile, it bleeds, it bruises, anxiety, TMD, migraine, facial pain, poorly formed molar teeth, white spots on the teeth, fast and painful orthodontic treatment. They can have a lowered pain threshold. They can be sensitive in medical issues. And we'll go through those issues later on, okay? So when do I find patients? I can find patients when they come to see me to have their carious, decayed first molar teeth removed. Okay, so maybe see them at the age of 8 or 9. A lot of the time the dentist would remove these teeth, but if they're finding a difficulty managing the patient, they would get sent to me. I then see them when they're a little bit older, maybe the age of 12 or 13, when they're having their braces done, their teeth straightened. The dentist again would do most of these, but I get them if they're having trouble, if they can't get the patient numbed up, if they say the patient's anxious. I then see patients like yourself, Byrdie, when they come along to have their wisdom teeth out. I see patients who are anxious and have been referred for sedation. Most patients I see with jaw joint issues actually end up being undiagnosed connective tissue disorders. And the same with the facial pains. And again, I don't just see the patient with TMD and facial pain when they're starting on their journey. It's when the dentist is struggling or the patient is struggling and they somehow find me. We also get some unusual things. So we had a patient with bad breath for 40 years, and we got this sent to me. And I said to our treatment coordinator, what do they want me to do? What am I going to do about this? Do you want me to charge the patient? I'll give them a pat on the back and say, I can't do anything else. Patient was very sure she wanted to come and see us. She hadn't heard of Ehlers-Danlos. But when she came, she was very obviously an undiagnosed Ehlers-Danlos. She has since seen Janet Gravener, and she's been diagnosed with Ehlers-Danlos. For 40 years, this had affected her marriage, her job, her socializing, and this is why we're needing to pick up these cases. We're also seeing a lot for you oral med guys in the audience. I'm also seeing a lot, well, we've seen sort of 4 ladies in their 20s and 30s with lichen planus. We biopsy them, they're lichen planus, and we're suspecting an undiagnosed connective tissue disorder. These patients have gone on to be diagnosed with hypermobile EDS, and I'm just wondering if there's a link there that we haven't yet seen. And we also see some with angina hemorrhagica bullosa. I've seen 2 like that, and they have been undiagnosed EDS. So there's just a lot of things here that we need to think about and talk about. So some patients that could walk into your clinic here. We've got Russell Kane, Billie Eilish, Deliciously Ella. All these people have been diagnosed with Ehlers-Danlos or hypermobility spectrum disorder. And I think you'll agree, they all look pretty healthy. They've all spoken openly about their EDS as well. So this is Ella, Deliciously Ella. Now, she was very ill when she was a student at St Andrews. She took a very long time to diagnose. She's now written cookery books and she's got her website and everything else. She's quite open again about how she talks about this. And she talks about it in the front of her cookbooks. She's got Ehlers-Danlos, she's got POTS, and a condition called mast cell syndrome. We then move on. We've got Jamila. So we've got Sia, the singer. We've got Jamila. Now, Jamila's done really good podcasts on everything, including her Ehlers-Danlos syndrome. So, Linda, when I'm traveling to work, I work all over Scotland. When I'm traveling to work, I quite often listen to your podcasts. Sometimes I listen to Jamila's as well. She's very vocal on it, and she explains it very, very well. Now, we mentioned Rodney Graham before. Jamila actually appeared in his research papers when she was a 7 or 8-year-old child before she became anywhere near famous. We've also got Selma Blair, we've got Lena Durham, and we've got Daisy, who is an award-winning author in Glasgow. And she had a very good article in one of the Sunday newspapers earlier this year that I think a lot of us have shared. And she said something I think that resonates with a lot of EDS people. Despite how she looks, I finally realize I am not able-bodied. And I think that is a journey a lot of EDS patients go through, that they have been gaslit, they've not been believed, and that is how they feel. So all these people look very, 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 very healthy, but they could walk into our surgery and they'd be looking the same, and we have to know how to pick them up. So when do I suspect? So this was a case I was sent the day before my clinic, and Jacqueline, you might want to help me on this. Do you want to hop on your mic there if you're allowed to? If not, Alexandra will get Jacqueline Thomas. So this was one that was added to my clinic the day before. 14-year-old girl. She's got her first molar teeth missing here, very carious first molar, but everything else looks okay. So I'm wondering if this is a case of molar incisal hypomineralization. She's also got a missing permanent tooth down here. So before Jacqueline and her daughter came in, I was ready for you, Jacqueline, wasn't I? You had no idea. You had no idea, Jacqueline, but I thought, okay, I think this might be another Ehlers-Danlos case. Occasionally, it's not showing it well here, but in Ehlers-Danlos cases, we can also have fused roots of the upper sevens and toroidism and things like that. That is when I might suspect, yep. So, Jacqueline, I work with such supportive nurses and managers and my treatment coordinator. Staff often pick up the cases before I do now, okay, and they quite often nudge me. They gave me a little nudge before you came in as well over that x-ray. So these are undiagnosed EDS cases, but they've already done things to get used to their issues and to manage their issues. So in waiting rooms or say colleagues, dental colleagues, nurses colleagues, there are quite a few things that we can see that lead us to suspect they could be Ehlers-Danlos. So some of these things are, and Jacqueline, if you just want to tell us about your daughter, is she anxious and sensitive?
Highly.
Absolutely. They overdress for the weather.
Yeah.
Yep. They wear very soft fabric sometimes. They can keep moving because of their blood pressure issues and their POTS, which we'll talk about later. They can be walking up and down the waiting room looking as though they're not patient, but this can be a blood pressure issue. They then, if you tell them to sit down, they might cross their arms and their legs. And that again is putting pressure on their vena cava and their venous system to get their blood pressure back up. I'm not even going to try and say that word today. They can look 10 or 15 years younger than they are. And I know, Anne, this is something that you know about as well. People do not think that you're the age that you are. Yep. They can have white spots on their teeth when they smile. So I quite often have nurses who work with me. After working with me for a couple of sessions, they say, Audrey, do you mind if we have a bit of a chat? Yep. And these are the people, and dentists as well, these are the people that maybe bruise easily. You see bruises on their legs and arms and they don't know where they came from. Jacqueline, is this familiar to you as well?
100%.
Yes. They can be clumsy, but they can be very good at Pilates and yoga. Mm-hmm. Yeah. In our Glasgow practice, we have a guy that helps us, and he quite often offers the coffee to them. So a lot of people with Ehlers-Danlos, because of their dysautonomia, they can't do caffeine. So these would be the ones to say, do you have any decaf? And it's just another little sign and symptom. A lot of people with EDS, they have dietary issues. Some of them cannot do milk. So these are the ones asking for the soya milk, and Caitlin, our manager, has to run off around the corner to buy the soya milk. They need to maybe keep up their fluid intake. So I know a dentist that came on one of our lectures, he managed to pick up a patient because they had a very large water bottle. And when they're sitting in my chair as well, one of the first things I see is they maybe have very, very bendy fingers and thumbs. And that is my sort of way into saying, I wonder if the local anaesthetic is not going to work. Yep. So here we have Emma. So Emma, if you want to help us out with this, Emma's a 32-year-old lady. She came to me for TMJ issues and a carious wisdom tooth. The referral said she was anxious and tearful, very hesitant to seek help. And I suspected, Emma, about you the day before you came in, and we've spoken about this a lot, haven't we? And she's a great example of the difference that we can make. And in your medical history there, Emma, I really felt that was a bit of a giveaway, and I think you would know now that if you came across somebody like that, Emma, that would be a giveaway. Your gastric reflux issues, your GI issues, your functional neurological deficit, tingliness up your arms and legs, all this was in her medical history. So it was a bit of a gift to me there. So Emma, do you want to just tell us when you came in, do you want to read this, or do you want me to read this? Do you want to say what you said in your feedback to us? Are you there?
Yeah, absolutely. So, yeah, I'm here. Can you hear me?
Yeah, we can, Emma. Yeah. So if you just want
Yeah.
to read this,
Yeah,
read
Grant.
the slides, great. So you
Yeah,
had,
so I did. I had a whole host of health problems for 20 years. doctor said, oh, it's all in your head, was sent to psychologists because they said I had health anxiety, and went through a ridiculous number of specialists and treatments, and walked through into the dentist after having given up, basically thinking that I'd ever
walked through the door, and you said you thought I instantly knew. Yep. So you said you were so emotional to finally sit in front of somebody who was listening and understanding and able to explain it all. With you, it was instantaneous. It was a light bulb going on. You completely got it. You completely believed us. And you said you now feel so empowered to understand your health now and improve it. And I find most of the patients I find are like Emma. They are not going to be victims. They're not going to sit there and cry. You were so on it, Emma, to move on and improve your health. So thank you very much for that. So Emma, if you stay with us, when you were in that chair, a couple of minutes after you realized, you said to me, so do you mean I had to come to the dentist to be told this? And you drew me a look, but I knew you weren't drawing me a look. You were drawing a look to every other healthcare professional you had ever seen, because it just seemed so simple and easy to understand. You had been misdiagnosed for about 20 years. And I think you now agree that anybody could have seen this. Yep.
Yeah, absolutely. I think having done these talks with you for quite a while now, and the understanding that I have, it boggles my mind to think that I was walking into doctor surgeries and hospital appointments, and they didn't spot me as soon as I walked in that door.
You had a neon sign over your head and nobody saw it, yeah? So everybody in healthcare is coming at this from different angles. Here we have Alan Hakim having a look at this elbow joint. Tara, I think this is you trying to decide if these are canine teeth. We've got the dermatologist here having a good look at the skin, and the GI surgeons going to do a colonoscopy there, yeah? So Emma, any of your clinicians could have picked this up, yep? I speak to my hairdresser about this. My hairdresser has started picking up cases. And Emma, I know at work you spot cases amongst your colleagues. You go about it very gently. You maybe tell them about your issues and then they open up to you. And I know you've come across a couple where they have now realised what is going on. So Emma, why didn't your doctors and healthcare professionals pick this up? I think it's very important to realise that there's no role for doctor bashing here. Yep. In the past couple of years, I've picked up 2 GPs myself. Linda, you don't mind us sharing that you also have Ehlers-Danlos? You're so open about it in your podcast that I know you won't mind us sharing that. You know, Linda was diagnosed, I think, about the age of 48.
Yes.
Yes. So, you know, again, there was a sort of 20-year delay. So even doctors don't get this. Everyone is trying their very, very best. So EDS is nothing new. This man in 400 BC spoke about EDS in his writings, Airs, Waters and Places. And, you know, he said about the lax joints. This is thought to be the earliest mention of EDS. We didn't have poodles back in that time, but this was 1980 when I was at dental school. We did have poodles, and this is what poodles looked like in the 1980s, yes? And I feel it's a very similar story to Ehlers-Danlos. Sorry, I'm doing the wrong thing here, yeah? So when I was doing medicine and surgery at dental school in 1984, and this is what I believed until 2018. I still remember it very clearly. I don't know why I remember this from medicine and surgery, but EDS was blue sclera, stretchy skin and mobile joints. And when my friend Joy mentioned this about this patient to me, I said, you're talking rubbish, you're not right. What are you on about? And then within a few minutes, it was, oh my goodness, she knows what she's talking about. Yep. That's only part of the story because that's only one type of EDS. As we saw from the 13, 14 types we have, this is probably classical. There's many, many other types, and hypermobile doesn't appear just like that. So Linda, we'll ask for your help with this slide here, okay? If you could maybe just give us a minute or two on this slide, yep, explaining what the slide is.
Yes, absolutely. So we don't necessarily understand why this is the case, but we know that people who have symptomatic joint hypermobility, whether it's a type of EDS or HSD, have a much higher incidence than the general population of having dysautonomia, so dysfunction of the autonomic nervous system, which is everything that we don't think about. So it's the function of our gut, our temperature, our blood pressure, our heart rate, the size of our pupils. So people run into problems with upright posture. They don't compensate well. So they might tell you that they have difficulty with temperature regulation or that they get dizzy when they stand up. And of course, any of us, if we've had the flu, when we go to stand up, we're going to get dizzy because we're, decompensated if we've been in bed for a few days. This is more, it's been happening for a number of months. So that's the dysautonomia or autonomic dysfunction part of it. They may or may not meet the criteria for POTS or neurocardiogenic syncope, but that's that part. And then we also see a much higher prevalence of mast cell activation syndrome. And this is where the mast cells, which are part of our immune system, that live in our tissues, and especially where we interface with the environment, but these cells become more reactive than they should be. So instead of, reacting under circumstances where we have a virus or some kind of infection, they're reacting to a whole host of things, and it could be internal or external stimuli. And we see things like itching, flushing, rashes, hives, could be gastrointestinal, a whole variety of things.
Yeah, so that's great, thanks. So, Anne, I'll maybe ask for your help with this one. This is a busy slide, but it just shows all of the different things that somebody with EDS can be suffering from. So,
and yeah, so if I look at that slide, I could probably tick every line on that diagram in terms of what I have experienced
yes,
over my lifetime. And
yeah.
a bit like Linda, I was diagnosed formally when I was 47. And I'd been suffering for many, many, many years prior to that.
Yeah. And when we look at this, Anne, and we look back, you could maybe have been picked up decades earlier, and it would have made a difference.
Yeah.
So, Linda, I know you've done a really good podcast with Jessica Eccles. So would you like maybe just to give us 30 seconds or so on this?
Sure. And I will confess, I was diagnosed with ADHD and EDS like around the same time, also later in my adult years. And yes, much more likely to see neurodivergency. So autism, ADHD, dyslexia, all of the things that are on this slide. So when we see people that have these things, that should also be making us think, oh, could this person have a hypermobility condition?
Yeah. I think it's very important not to just stop at one label, not just to be ASD and that's it. We need to look for other things. So, Anne, we'll ask for your help with this one as well. Sensory perception sensitivity.
Yeah, so for me, I am hypersensitive to whether it be the weather, different smells, touch, but also like if I do walk into a room, I pick up how people are feeling, the atmospheres. Yeah.
Yep. And
extremely hypersensitive.
You can get everybody's stories out of them just by looking at them, can't you? And you're a wonderful listener.
I get called the White Witch.
Yeah. So it also makes your life richer, but it does give challenges. So on to the next slide here. We've seen there's many ways to present as with having Ehlers-Danlos syndrome, and this is a very good way to represent what it is. What it said is if you know one person with EDS, you only know one person with EDS. Some people might have more joint issues, but not many GI issues. And the other way around for the other person. We've also got to remember as well that EDS changes throughout life. So you might be one way at one time, but get completely different another time. This was going to be a slide I had Alan do for us, as well as the chronic issues. We can also have serious bleeds. Jacqueline, you're coming in to help me with this one. Okay. So we can have serious bleeds for many different reasons. Patients with Ehlers-Danlos, they bleed much more than other people. And this could be after trauma. When I take wisdom teeth out, I notice it. When I put my number 15 blade in there, I know. So have you had experience, Jacqueline, of bleeds?
Well, I did after I had my daughter. I was terrible. I
almost died.
I was almost near dead then. Yeah,
a serious postpartum bleed. We can also have aortic dissections. I have been involved with a fatal one, and I also predicted another one. I know another medical professional that told me they had a 16-year-old girl very sadly die. And if we can pick up EDS cases, we are more aware that this might happen. A pneumothorax, I know Janet and I share a case. I'm keeping everything confidential here. Janet and I share a case of a gentleman who is very much EDS, and 15 or so years ago, he had a pneumothorax for 2 days before the doctors would believe him. Then he eventually got his medical help. We can have bowel and uterine rupture, and we also have a much increased suicide rate. And I know, Jacqueline, maybe you want to say something about that.
Yeah, I lost my brother to it 4 years ago.
Your brother wasn't diagnosed with EDS, but looking back at it now, you very strongly believe, and thank you so much for sharing that with us, Jacqueline. It's very, very hard. And another reason for picking these up, Anne, I know you will agree as well, and I know we can talk about this. There was one of the EDS members in Scotland died by suicide.
Since we've started volunteering, we have lost 6 members, including 2 volunteers, to suicide.
I didn't know it was that high. So it's another reason why we need to pick up these cases. Okay. Thank you for sharing that, especially Jacqueline. So we all have had medical professionals say to us, there's no point in knowing this as there's nothing that can be done about it. So Linda, can you give us a quick chat on this?
Yeah, when I was diagnosed in 2012, this is exactly what I was told. And I don't have any of those red flags that you mentioned on the previous slide, for genetic testing. Those are all things where, for me anyway, if I hear about somebody having a pneumothorax, I definitely would say, okay, we probably should genetically test you. But yeah, there's so much that we can do. And I know we're going to get more into this later, but yeah, I completely disagree with that sentiment, but unfortunately that sentiment really does persist.
Yeah, that we need to we need to investigate them, we need to diagnose them, and there's so much we can do with the treatment, and we could talk for hours on this, and we'll be happy to talk for hours another time, or I can direct you to Linda's podcast, because good podcast on everything. Okay, so Linda, another one for yourself, please. This is maybe just explaining about the last slide as well. I heard this on one of your podcasts, and I thought this was quite good.
Yeah, so it started out selfishly. I was just trying to get my own health improved. So I started reading all these articles and trying different things. And somewhere along the line, I was talking to my husband, who's also a physician, and I said, I need to come up with some way of explaining better what it is that I'm doing for myself. And then I started trying it on other patients and found that this is a good way to explain the comprehensive treatment plan that I use.
Yeah.
So the MMS.
What I liked on your podcast was you said if you can get a 5% benefit from each of these things, you add up that 5% from the sleep, from the diet, from the psychological, from the drugs, that's a real big improvement there. So Jacqueline, we're going to ask for you to do this slide. The biggest communication problem is we do not listen to understand, we listen to reply. This was said by Stephen Covey. So I think, Jacqueline, you were going to tell us you had a 50-year delay in diagnosis.
Yeah, absolutely. I just believe that I might have been diagnosed all that time ago. It just saved me a lifetime.
Yes.
Honestly, it just...
And you felt that the doctors never really listened to you, and that was why you didn't get a diagnosis. Yep.
Never. It was just, they didn't for me.
And you felt when you came to our Lockerbie clinic that maybe the light bulb went on, didn't it, Jacqueline? The light bulb went on. When I said something, you were completely on it, yes?
Honestly, it was the best thing I ever did was to walk in there.
Jacqueline saw her doctor for an EDS diagnosis. I saw her in clinic 3 weeks ago, Jacqueline. Yep. You have moved on to appearing on podcasts 3 weeks later. On average, there is a 20-year delay in diagnosis, and this is from an Edinburgh publication from our colleagues Catherine and Derville. Yeah, so a 20-year diagnosis, yeah. And what happens in that time? People get gaslit, they're in limbo, they become more unwell, they've got long-term physical and psychological harm, unnecessary appointments, investigations, treatments, medications. And I know Janet and Anne and Byrdie, you very much have gone through this. Unnecessary appointments, investigations, treatments. We're wasting NHS money. And when you think of the number of cameras and scopes you've had up, down, in between, scans, MRIs, CTs, it's really quite unbelievable. We can save so much NHS money on this, and the toll inflicted on individuals, families and workplaces. Yeah.
Absolutely. Yeah.
Yeah. So Linda, again, as you would expect, has got a very good podcast on this. I can't remember the doctor's name, but he was talking about the damage doctors did to their patients. Yeah. Do you remember that podcast, Linda? And that's a great one to have a look at.
I can put that in the chat.
That would be great. Wonderful. So how do we get a diagnosis? It's not an exact science. To me, it's a bit like trying to diagnose a diabetic without having a blood test. Yep. And these are some things from the Hypomobility Spectrum Association, a colleague of ours, Phil Bull. If you go to the website, you can get these. So what we've got, what we've got to do, first of all, is to see if they're hypermobile. To me, I'm not overly fussy about that. And I know Alan Hakim agrees with this. You don't have to be overly hypermobile to have a connective tissue disorder. I maybe didn't make that point earlier on. I can see Linda thumbs up and nodding. A lot of the patients I find, Linda, are not overly hypermobile. Yep. So we need to see if they're hypermobile. We need to see if they're hypermobile by the questionnaires. We need to ask the standard questions. There's not a, if you get a 7 out of 10, you've got EDS or whatever. It's not an exact science. We need to know when to genetically test. This is where I think it's Claire Francomano's red flags come in that Linda's going to put on for us, and then we need to know what to do. Okay, so these 10 questions are something that Phil Bull says are quite good to ask. We've run through some of these already. Yep. So coming at it from a rheumatology angle, there's a few other things Janet and I like to ask, and that's about stretchy skin, translucent skin, migraines, looking younger, and local anaesthetic not working. So we've made our own template for my clinic. Byrdie, I think you're maybe there if you want to join us. When Byrdie came to our clinic, hi Byrdie, and we were asking you questions. How did it feel, Byrdie, when I was asking you these questions?
I think I was like, how do you know these things about me? Things that I hadn't told anyone or hadn't even really admitted to myself, I guess.
You felt almost as though I must have been stalking you. And yeah, and one of the questions I asked you was, do you have white spots on your heels? And I think that just did it for you. It's like, who is this woman?
Yeah, because I'd never told anyone about them because I thought, oh, those are really weird. I don't want to talk about them. I don't know why they're there. I'm going to pretend they're not there because
yes,
I thought no one's going to believe me if I say I've got weird white dots on my heels.
Yes. So it's sometimes we've got to be very careful how we're asking these questions, and it can really, really throw patients. Whereas Jacqueline, just the light bulb went on immediately. Byrdie, because you think things out. You've got several degrees in psychotherapy and whatever else. Byrdie wanted to think this out. She only came to have a wisdom tooth out, didn't you, Byrdie? You just really wanted me to get on and do that for you.
And you didn't even take it out.
I didn't even take it out. Exactly. So let's look at the classifications for being hypermobile, because Byrdie, you were hypermobile. Yeah. I can't remember what your score was. So this is the Baton classification. It's been around for absolutely years. You get a score out of 9. I think anything over 4 or 5, depending on your age, you're classed as hypermobile. But as Alan Hakim and we all say, it doesn't really matter if you're hypermobile, because there's so many different ways of having a connective tissue disorder. So 2 guys, Alan Hakim and Rodney Graham, they came out in 2003 with a different questionnaire, and that is a 5-point questionnaire. And this is pretty good because there's a sensitivity and a specificity specificity of 83% and 89%. So Linda, this really does show very well whether somebody is hypermobile. Yep. So the hypermobility is only part of it. So as we said, the most common form of the connective tissue disorder is hypermobile EDS. So we move on to the International Consortium of EDS and related disorders as sort of toolkit to see if you fulfill the criteria. This is fine if you fulfill the criteria. Yes, you get your label of hypermobile EDS. If you don't quite get there, you can be labeled as hypermobility spectrum disorder. There's a lot of things that we might think, why is this in it? I know as dentists, we might be querying the dental crowding and high or narrow palate. To me, everybody has crowding and a high or narrow palate. A lot of people do, but even if they didn't, how do we measure a narrow palate? I realise we're a little bit short of time, so I'm just going to press on to the next one here. This was really maybe thought of as a research tool. Yep, it's very good for research, but it's pretty difficult sometimes to get people diagnosed. But Linda, I'm going to ask for your help with this next slide if we can. Yeah, this was a paper that came out earlier this year. You'll be aware of this paper, I know, Linda, because you've spoken about it, yeah? So if you want to just give us a minute or so on that.
I mean, this is just a study where they were looking for like biomarkers, and they actually found very similar biomarkers for HSD and hypermobile EDS, and those were different than the biomarkers that they found for, I believe that they looked at psoriatic arthritis, and they looked at maybe classical EDS. I haven't looked at this for a little while, but it was really, really interesting because basically the question that came out of this paper and this study was, are hypermobile EDS and HSD, like, are they really actually that different, or should we be defining them differently so that they are actually distinctly different conditions?
Yeah. Yeah, so that helps us move on. A few complicating factors. We have to be aware that signs and symptoms of long COVID and Lyme disease that can be very similar to signs and symptoms of EDS. And so we have to be careful that, yes, they might have long COVID, but they might also have EDS, and the long COVID might have uncovered their EDS. Patients with EDS are much likely to get long COVID as well. So there's a lot of stuff going on. Diagnoses are also missed at times of puberty, pregnancy, and menopause. Fibromyalgia, Linda, you'll maybe help me with the figures here. I think there's an 85% sort of crossover.
So I would say amongst my patients, I would say 100% of them have pain hypersensitivity. They have central sensitization and nociplastic pain. I would say 100% of my patients.
Okay, that's fine. The paper I saw 85, but I am willing to go along with that because that is what I see on clinic as well. Yeah, so we need to have our minds open if a patient comes in with that in their medical history. Yep. Other traumas or life changes, it can just be a time when we can pick these things up. So we need to be careful we're not being misled. We're not going to be careful we don't stop at one diagnosis and not to miss diagnoses there. So you came to us here to see about the dental and the oral issues. So let's sort of move on to these a bit. The first one we've got here is difficulty with numbing up patients on our clinic. I now ask my patients in my history before I see them 3 times, do they go numb at the dentist? I say to them, it's not enough telling me your lip goes numb. It's not enough telling me the dentist says you go numb. And it's not normal to feel pain when you are numb. And I can see Anne smiling away there. Anne and Byrdie and Emma, yes, all have failed local anaesthetic. Byrdie, I wasn't going to take your wisdom tooth out for you. I said to you that first day I saw you, yes, I said to you, these are far too difficult. You're far too difficult a case for me. You need to go to hospital. You need to go for a GA to have these done. And Byrdie and I have become very good friends. So we can laugh together, yes?
I refuse to get the general.
Sorry?
I refuse to get the general.
I refuse to have a general. And she said, but Audrey, I'm going to trust nobody apart from yourself here, yeah? And so we took out very badly impacted wisdom teeth, very close to the nerve, very poor access. Byrdie, you gave us everything. You gave us everything that was hard there, yeah? Local anaesthetic did not work for you, as it's not worked in the past. But what I find with a lot of these patients are, and I had another one this week, they are so patient with us. You were so patient with us, Byrdie. You were so understanding. You helped us as we made our way through different local anaesthetics. Yep. So we have to ask if local anaesthetic works. And you all would have been, Emma, if you can tell us, you were told you were just being silly. You were told to pull yourself together many, many years. And that was why you were so anxious. Yep.
Absolutely. I had a dentist laugh at me because he said there was no possible way that I couldn't be numb.
Yes, and so by the time you came to see me, you were a wreck and you didn't want to meet me. Yeah, so this makes this makes an anxious person even more anxious. I've also had to explain to a final year medical student and a dentist what successful LA is. These were people with EDS where local wasn't working and they didn't even realize for themselves it wasn't working. Yes. Patients can become anxious. Patients are anxious who have EDS. It's inbuilt. And we could talk all day on all this, and I know we don't have enough time. So we need to understand them. We need to give them time and understanding. And Byrdie, you were anxious. Emma, you were anxious. Byrdie, we gave you a little, we just listened to you. And you were the best person in the world. And can I just say, Byrdie, I am really surprised that you are here, because a week ago?
Yeah, 8 days ago, Audrey took out my impacted wisdom tooth on this side.
And it was horrendous. And I didn't think she would be sitting here talking to us today. So when you get on the same side as them, when you say, we understand, we know, not just tell them they're being silly. And I think as well, if you've got that understanding, it makes your healing quicker. Yep. Yeah. So where are we here? Where are we here? They can bleed easily. They can bruise easily. I know when I first put my number 15 blade into the tissues, these tissues are not normal. Yep. They bruise, they bleed, the mucosa is fragile. TMJ issues and facial pain, we'll talk about that in just a little bit. They can have the high arched palate. They can have the muscle tiredness. Very difficult taking a impacted canine out of a high arched palate. They can have the poorly formed teeth and the white spots in their teeth. They can have pulp stones that makes endodontic treatment harder. Different shapes of roots. They can also be very sensitive. So Anne, from what you described, you are going to be so aware of maybe the colour of a filling, a shape of a filling. If you're having your teeth straightened, you would think, no, that one's just a little bit out of line. So these people are not being difficult. It's just the way they're made. Yep. So, Linda, could we maybe come over to you as well? I think you know this paper very well. This is the best paper we've got on local anaesthetic. Do you want to do this one, Linda, or will I? Will I do this?
Yep. Go for it. Go for it.
I go for it. So, local anaesthetics do not work well in patients with Ehlers-Danlos. And this is the best paper, 2019, that we've got at the moment. We're needing much, much more research on this. Okay, we've now got 36 people in this, yeah? And Alan Hakim's name is there as well, yeah? So there's maybe, things that could have been done better with the paper, but it's an absolutely wonderful start. So what this paper is saying is we have inadequate control in 88% of EDS patients versus 33% of control patients. So this is what you guys are backing up. The local anaesthetics that work the least are lidocaine, prilocaine, mepivacaine is 22% successful, and the best one is this one down here at 30%. So when we're working away, we need to decide what local anaesthetic to use, and we need to try and get you numb. So that's a good paper. Again, we could do a full talk on this, yeah, but we just don't have time, yeah? Why doesn't it work? It's poorly understood. It could be mast cell activation, abnormal connective tissue pathways, altered pain pathways, yep. So I know we've got Tara here today, and Tara, this was the reason we had this talk. I know we're going to run over a few minutes. I hope that's all okay with you all. As I said, I find undiagnosed connective tissue disorder in most of my TMD patients, and all of them are going towards diagnosis or have been diagnosed. It's very relevant to management, and we need much more knowledge of this. So Tara, are you there, and do you want to say something, or are you busy there at the moment?
Yes, I'm here. It's not Tony. I'm using my husband's Zoom. It's fantastic talk, and thank you everyone. This is just brilliant. I'm actually at a headache conference in Rotterdam at the moment, and EDS is not mentioned, which makes me very sad. I mentioned it in my talk, but particularly with arthrogenous pain, it's a real relevance, but it is with any joint pain particularly, and it hasn't really been much explored in headaches so much. Although actually, I think with comorbid fibromyalgia, migraine, neck pain, and back pain, there must be something going on there. But thank you for this, Audrey and Linda, and your fantastic patients. It's a really great talk.
Yeah. Thank you, Tara. There is so much more we need to look into this. I know there's so many people from oral med, oral surgery, whatever backgrounds. We want to take this further, and the point of this talk is so we can take it further. So I've just rushed through the next slides. So what do I do when I suspect we've got a case? We do an extended medical history questionnaire, which Byrdie and the rest of you are all aware of. I say, have you considered your seemingly unconnected signs and symptoms could be connected? We remember a differential diagnosis, and most people have been looking for answers. And, you know, Jacqueline, it's just absolutely great. And, you know, Emma and Byrdie, it's absolutely great to be able to help you guys. Almost everyone welcomed the knowledge. The ones that don't have just said, oh, it runs in the family, I don't need to know about this. Then what we do is we email them a link to references, a letter to their GMP and to specialists so they can show it. We refer them to specialists, rheumatology, genetics, osteopaths. Most of mine go to Janet because I know they're going to get absolutely wonderful care there. We give them the EDS Support UK information, and then we try, Byrdie, to deal with the reason you came. And Emma as well. Almost forgot about you that day, Emma. Yeah, remember that? You said, you're not going to do something about my tooth. So what I ask when I do these talks to the general dentist, I say, look for cold hands. I always shake my patients' hands now when they can. Look for cold hands, younger looking skin. Look and see if your patient's anxious. I see all the medical history is relevant. And I know, Tara, this is something that you and I have spoken about, and we get us equally mad about this. All relevant, all medical history is relevant. I want to know if they've had a pneumothorax. I want to know if they've got reflux. Yeah. We have to ask about LA issues. I make that a standard question, and I ask it 3 times before I even touch the patient and see the case as a whole. So the summary is, it's very poorly understood. It's much more common than we think. We need to be able to identify signs and symptoms. There's many considerations for treatment. Every patient with EDS is different, changes throughout life, and the dental team has a huge role to play. So what are we going to do now? We need to get knowledge to as many people as possible. We need to get it in the medical and dental school curricula. We need assessment tools for dentists, so they've got a bit more of an idea what to do. We need to see if we can work with the International Classification of Orofacial Pain, the TMD guys, the BAOS, the British and Irish Society of Oral Medicine. We need to get research and publications out here. So if you need help on these talks, we always find people affected by these issues on our talks. We always pick up people that thought, oh, it was normal to feel like that. So you can speak to us. I'm Audrey. Linda, I've taken the liberty of putting your details up there in case people want to get in touch with you. There's the EDS helpline. There's the HMSA helpline. After one of these talks, I actually had somebody ask if they could move in with me. I'm not taking any more lodgers at the moment, but we're here to help as we can. So just seeing what slides we've got here. So thank you very much for listening. Thank you, Linda, for joining us, because I know this is a hectic time in life for you at the moment. Thank you, Anne. Thank you, Byrdie and Emma and Jacqueline. Your inputs was wonderful. And I would like to ask if anybody has got any questions. I know we've run over by just a couple of minutes, but if anybody's got any questions, please let us know.